A severe case of thrombotic microangiopathy after liposuction. A 48-year-old non-obese woman with hypothyroidism presented for 2 days of decreased urine output, constipation, and new-onset epistaxis 5 days after liposuction. Medications included moxifloxacin, pregabalin, COX-2 inhibitor, and levothyroxine. Preoperative laboratory workup was normal, and she had no personal or family history of coagulopathy. Upon admission, blood pressure was 122/88 millimeters of mercury, heart rate 77 beats per minute, respiratory rate 15 respirations per minute, temperature 37 degrees Celsius, and saturation 97% on room air. Body mass index was 21.7 kilograms per meter squared. Physical exam revealed bilateral lower extremity edema. Skin, cardiopulmonary, abdominal, and neurological examination were normal. 2 groin incisions were present with no signs of superimposed infection. Laboratory data revealed a hemoglobin of 10.9 grams per deciliter with thrombocytopenia of 26,000 and a normal white blood cell count. Creatinine was 13.3 milligrams per deciliter and BUN 111 milligrams per deciliter. CO2 was 20 millimoles per liter and potassium 5.5 millimoles per liter. Anion gap was normal. Urinalysis revealed moderate blood on dipstick, 8 red blood cells, 5 white blood cells, and 3 plus bacteria. No casts or crystals were identified. Urine protein to creatinine ratio was 1.2 grams per gram and albumin 2.8 grams per deciliter. The pregnancy test was negative. LFTs were moderately elevated in a hepatocellular pattern, but bilirubin and INR were normal. Haptoglobin was low and LDH over 2000 with schistocytes on peripheral smear. Given concern for microangiopathic hemolytic anemia with renal failure, she was urgently started on plasma exchange until full workup for thrombotic microangiopathy (TMA) was performed. ADAM-TS13 activity was over 10% and stool cultures negative. Serologies for B12, HIV, hepatitis, vasculitis, antiphospholipid syndrome, scleroderma, and systemic lupus were all normal. C4 was normal and C3 was slightly decreased. No medications commonly associated with TMA were identified. Anticomplement therapy was therefore started. A kidney biopsy revealed exclusive glomerular thrombotic microangiopathy with endotheliosis, mesangiolisis, with minimal focal fibrosis of 5 to 10% and severe tubular injury. Immunostaining was negative and arterials were normal. Findings supported TMA due to complement-mediated hemolytic uremic syndrome. This is a severe case of microangiopathic hemolytic anemia, thrombocytopenia, and renal failure requiring hemodialysis. We suspect the postsurgical pro-inflammatory state triggered the disease as extensive workup was unrevealing. Genetic testing for acquired or inherited TMA is indicated to gain further understanding of her presentation. A few case series of post-surgical TMA have been reported following major orthopedic or cardiovascular procedures. No cases have been related to liposuction or the medication she was prescribed. TMA carries a high mortality risk if prompt treatment is not initiated. In addition to plasma exchange, immunosuppression with steroids and rituximab or eculizumab should be individualized based on the underlying etiology. A wide range of differential diagnosis needs to be considered by the treating clinician. Kidney biopsy is not mandatory for diagnosis, but will help evaluate for secondary causes, determine extent of ischemic injury, and potential to recover.